Hi, everyone. I'm Jordan, and I'm a student in the FNP program at Regis College. This is my flashcard presentation regarding endocarditis for our pathophysiology class. So I'm going to start with the disease process, and it's important to know that endocarditis is the inflammation of the endocardium. And you can categorize endocarditis as either non-infective or infective endocarditis. In both forms of endocarditis, there's a presence of vegetation on the cardiac chambers and valves. And with non-infective endocarditis, you will see that the vegetation occurring consists of platelet aggregation and fibrin, while infective endocarditis is the colonization of virulent microorganisms within the endocardium. So the etiology and pathophysiology of non-infective endocarditis is poorly understood, but researchers have worked at great lengths to understand infective endocarditis because we typically see it present more in the clinical setting, and we like to categorize it as either acute or subacute. So going through my card, I decided to break it up as infective endocarditis and non-infective endocarditis because they do have different clinical presentations as well as pathophysiology and risk factors. So starting with the pathophysiology of infective endocarditis, we know that this disease process begins when there's a formation of bacterial lesions within the endocardium. So those lesions form because of a presence of valvular insufficiency or endothelial damage. Those predisposing factors will be gone over in the risk factors section. So once that bacterial lesion becomes established, there's an inflammatory cell signaling process that occurs, and those proteins are released and are followed by the expression of fibronectin. So that inflammatory process consists of orchestrations of cytokine production, integrins, and tissue factors. So once that process is complete, monocytes and platelets are attracted, and we see an associated production of fibronectin further occurring. Monocytes become involved, and that's because of the effects that are induced by chemokines, which are known for stimulating the migration of different types of white blood cells. So I decided to go farther into the involvement of Staphylococcus aureus because it is the most common microorganism that we see in infective endocarditis. So with Staphylococcus aureus, we will see that it's binding to endothelial cells, and that's done through an extracellular matrix binding protein activation. And that bacteria is then internalized within the endothelial cells and invades the host immune responses. So Staphylococcus aureus is essentially burying itself farther into the host's endothelial cells. So that causes a further activation of an endothelial cell response, and cardiac tissues are then destroyed through the release of exoproteins, which include nuclease, protease, and hemolysin. So it's important to understand that exoproteins facilitate host cell lysis. So in non-infective endocarditis, we will see that the initiating factor within that pathogenesis is still pretty widely unknown, but researchers do believe that that an endothelial injury occurs, and that's done so in the setting of a hypercoagulable state and increased turbulent blood flow. And those are key factors with the development of this non-infective endocarditis. So the combination of hypercoagulability, endothelial damage, and turbulent blood flow then promotes the formation of sterile vegetations on the heart valves. So within endothelial damage, it's important to know that cytokines such as tumor necrosis factors or interleukin-1 trigger fibrin and platelet disposition occurs. So within this hypercoagulability, we will see a decreased ability for the body to break down clots, and that's due to deficiencies or dysfunctions of fibrinolytic factors, which include tissue plasminogen activators, also known as TPA, or plasminogen activator inhibitors, which are also known as PAI1. So when we see turbulent blood flow, we consider what's called the Reynolds value, and that would be increased. So with the Reynolds value, it's a number that considers velocity, density, and viscosity of someone's blood, as well as the blood vessel diameter. So if the Reynolds number exceeds a critical value of 4,000, the blood flow is then considered to be turbulent. So all of those together contribute to why one would develop non-infective endocarditis. So the fibrin and platelets that are formulated within that process, they consist of thrombi, and it's wrapped in strands of fibrin, immune complexes, and mononuclear cells. So for the risk factors and why they occur in infective endocarditis, we most likely or we most commonly see it's in those who are participating in intravenous drug use. And that's because they are using contaminated needles and syringes, and that subjects a person to bacteria such as Staphylococcus aureus. So we also see infective endocarditis occurring to those who have implanted devices, and that would include cardiac pacemakers, implantable defibrillators, so ICD placement. And that's because they're just more susceptible to bacteria attaching to that device, which leads to infection. So we see patients who have artificial heart valves being more susceptible to endocarditis, and that's because of the bacteria wanting to attach to those prosthetic valves. And it's very similar to those who are on hemodialysis that have indwelling access lines. And that's because those lines have a direct entrance into the heart. So we see individuals who are over the age of 60 being at a higher risk of developing endocarditis, and that's because they are more likely to be undergoing these invasive cardiac procedures like the ones that were previously mentioned. So we also see those who have poor dentition or recent dental work done becoming more likely to develop endocarditis. And that's because we see these patients having open sores in their mouths, and these procedures open up different areas of the gums, and it allows for bacterial growth, and it will then lead into the bloodstream. So those who have non-infective endocarditis, the risk factors are thought to be rooted in those with autoimmune disorders such as lupus and antiphospholipid syndrome. So with both of those disorders, we see that individuals are at a higher risk for developing blood clots, and that's going to lead to the development of those sterile fibrin and platelet aggregates that we talked about earlier, and those are what the vegetations consist of within the heart. So other individuals who might be at risk for non-infective endocarditis are going to be those with disseminated intravascular coagulation disorder. It's also known as DIC. So within that, we're going to see abnormal blood clotting occurring throughout the body. And we will also see those who have damage that was incurred from different medical conditions that have happened prior to the development of endocarditis. So a great example of this is those who have rheumatic fever, because there's damage that occurs after that as like a sequelae. So there's valvular malfunction, and that's going to make someone more susceptible to developing non-infective endocarditis. So for signs and symptoms, we have with non-infective endocarditis, that patients with this might have a little less obvious signs and symptoms, but the clinical presentation would more so reflect the underlying condition that we think is predisposing a patient to non-infective endocarditis. So a great example of that would be those who have lupus. Those patients might present with anorexia, different cutaneous lesions, arthralgia, synovitis, but it still remains pretty unclear whether that's a true symptom of the non-infective endocarditis or that's just a comorbidity that you're going to see with, lupus or other autoimmune disorders. It's really rare that we would see a patient presenting with cardiac murmurs or heart failure, but it is important to know that the signs and symptoms of those with heart failure are going to present to you in the office with dyspnea, edema in their lower extremities, rapid weight gain, and then sometimes even jugular venous distension. So with infective endocarditis, we see that it presents in either a subacute or acute form. So I broke them up into two different ways. With the acute endocarditis, that's going to develop very suddenly, and that's life-threatening if it's not immediately addressed. However, when you have subacute endocarditis, it's going to be more gradual and subtle, and it could take from weeks to several months before it becomes life-threatening to a patient. So specifically with those signs and symptoms in the acute phase, you're going to see a patient presenting with a fever that's greater than 38 degrees Celsius. And that fever would be accompanied by flu-like symptoms like diaphoresis or rigor, so the patient's shaking. And then you will also see patients experiencing drowsiness, arthralgia, tachycardia, and edema that's in their lower extremities. In the subacute phase of infective endocarditis, a patient might have anorexia, splenomegaly, and something called Osler nodes. And so those develop typically within the hands. You will see the development in the slower part of the subacute phase, which includes septic emboli, and that's what's forming on the vegetations. So those emboli, can create vascular occlusions, abscesses, or secondary infections. So bacteria that derives from infective endocarditis can be released into the bloodstream, which would eventually cause a fever and other infectious processes. And when subacute infective endocarditis is more severe, that's when you'll see the congestive heart failure symptoms occurring. And so the signs and symptoms of that, again, are the dyspnea on exertion, weight gain, fluid retention, and edema in your lower extremities. So for diagnostic testing, regardless of the etiology, whether it's infective or non-infective, the gold standard is going to be to do a transesophageal echocardiogram. So it's also known as a TEE in the clinical setting. So the typical findings of that diagnostic test are going to show those vegetations. So when patients have infective endocarditis, that transesophageal echocardiogram would show cardiac abscesses, pseudoaneurysms, sometimes intracardiac fistulas. You can even see a partial dehiscence of that prosthetic valve that's become infected, or valvular perforation. So it's really important that the other diagnostic test that's being conducted is blood cultures, and multiple sets of them. So those who have infective endocarditis, we are going to see growth. So that's going to produce different types, such as the viridans group streptococci, the streptococcus bovis group, the fastidious gram-negative coccobacillary organism groups, Staphylococcus aureus, which we mentioned earlier, or an acute community-acquired enterococci. So those who have non-infective endocarditis, they should still have those blood cultures completed for diagnostic testing, because we know that when there's an absence of the microorganism on the blood culture obtainment, that we can differentiate whether this is truly infective or non-infective. So it's great because with infective endocarditis, we have developed something called the modified Duke criteria, and that allows for different combinations to be put together that would classify a patient to have infective endocarditis. So the different combos are either you're hitting two major criterias, you're having one major criteria and three minor criterias, or presence of all five minor criterias. So I went into further detail with that and just wanted to let you know that a major criteria is going to include positive blood cultures, a 2D echocardiogram that's going to show endocardial involvement, or new valvular regurgitation. So the minor criteria is going to include predispositions to infective endocarditis, which we went over earlier, the risk factors. We also see that minor criteria includes heart conditions, intravenous drug use, fever, vascular phenomena, immunologic phenomena, or there's microbiologic evidence of an atypical organism. So these are the references that I used, but overall it was very interesting to learn about this one because typically in the clinical setting, we are just seeing infective endocarditis, and a lot of nurses that I worked with did not understand the process of, or even the existence really, of non-infective endocarditis. We just typically see the infective one. So I hope that you guys were able to gain something from that the way that I was. Have a great week.